Hi everyone, Marián Švajdler speaking. Welcome back to Biophysica multi-head seminar. And today I've got only a couple of cases. The first one is obviously skin biopsy from, let's say, still young male patient from his thigh. And so with this excision biopsy with a lesion which goes deep down into the bottom resection margin, and we can see quite normally looking epidermis here, and quite a typical uninvolved zone of papillary dermis, and some quite blunt looking spindle cell proliferation here, and it's a little bit more hyalinized here. But this is quite good clue to the diagnosis, this entrapment of fatty tissue, although it's still quite superficial. But it also involves fatty tissue here, so it's a little bit infiltrating into the fatty tissue. Otherwise, the morphology is not very typical of the entity, although the cytomorphology is. So, you may say it looks maybe like weird, ordinary, or weird-looking fibrous histiocytoma. But it goes deep and infiltrates fatty tissue. So I have performed CD34 staining as a screening marker, and it's diffusely positive. So this is quite suggestive of Dermatofibrosarcoma protuberans, right? So some of these tumors may look very blunt and do not have this typical storiform architecture. I have performed fish studies, and the typical COL1A1 PDGFB fusion was confirmed. So this is example of Dermatofibrosarcoma protuberans. Be careful, some of these don't read books may look very blunt. You may miss the diagnosis, and if not completely resected, you may be sure that the lesion will come back and the patient will recur. So, wide surgical excision is indicated in this patient. Okay, my next case is older male patient, and he presented with intradural tumor of the C3 spinal region, so cervical spine. And in low magnification, we can see it's quite well circumscribed, maybe encapsulated lesion. And the differential diagnosis by clinicians were meningioma and schwannoma, which is reasonable. And already in the low magnification, you can see some very characteristic features of the tumor, including these funny-looking vessels. And we have some hypercellular parts and more hypocellular parts with more collagen fibers. And the tumor is composed of these very bland spindle cells. In this case, no mitotic figures were present, no necrosis. And typical markers for meningioma, like somatostatin receptors type 2 or EMA staining, were negative, as well as S100 and SOX10 stainings for weird-looking schwannoma were negative. And does anyone want to guess what it is or suggest one diagnostic staining? Yeah. So it's STAT6, and it's diffusely nuclear positive, so it's solitary fibrous tumor, formerly in the CNS called hemangiopericytoma. Nowadays it's called solitary fibrous tumor, just like in any other location. There is a specific grading system for CNS lesions, which includes a number of mitotic figures and necrosis. In this case, I was not able to find any mitotic figures. Necrosis is absent, so in this case it's grade 1. So most of these tumors occur supratentorially at the meninges, but some may occur in the spinal canal as well as a spinal lesion. Okay, my next case is another CNS case. Again, it's spinal cord lesion. In this case, it's intraaxial lesion, so intramedullary lesion of the parenchyma of the spinal cord. And we can see some blue stained, very hypercellular tumor. In high magnification, again, very highly cellular, but otherwise the cells look very much the same. It's not real pleomorphism. Nuclei are relatively blunt looking, roundish. Mitotic figures were very spare. In fact, I was not able to find maybe any. And as you can see already in the middle, some diagnostic features. It's true ependymal rosette present in the middle. And in addition, there were some vaguely formed perivascular pseudorosettes. You can tell they are there in the low magnification, maybe here. But still, many true ependymal rosettes are present as well. This is not very typical of spinal ependymomas. They mostly don't show true ependymal rosettes. And in addition, you can start seeing these lumen-forming structures called central canal-like structures. So this is quite diagnostic of ependymoma. In addition, in this case, I have to search for this. Yeah, more central canal-like structures are present, and you can see that very well formed, almost epithelial-like. And what is interesting in this case, some of these cells show these clear cell features. So some ependymomas may have completely clear cell morphology. Yeah, maybe some more true ependymal rosettes. Yeah. So spinal ependymoma. We have performed methylation profiling because this is the gold standard for classification, and it came back as spinal ependymoma NOS, so no other specific subtype of ependymoma. When you see spinal ependymoma, you should also do test for CMYC and NMYC gene amplifications, because there is special subtype of spinal ependymoma with, I believe, NMYC amplification, but I believe there will be cases with CMYC amplification, so I always test for both genes. And these are very, very aggressive tumors, mostly show high-grade morphology, including many mitotic figures and necrosis, but some of these cases don't show this high-grade morphology, so I screen in forward to see whether it's this very aggressive site type. So in this case, CMYC and NMYC was negative, so not amplified. So this is a spinal ependymoma. Okay. My next case is again brain tumor. So send in consultation. With this very nice morphology. This microcystic. When you see something like this, it's almost always glial tumor and astrocytic in origin, but also oligodendrogliomas may show this microcystic architecture. So there is some nuclear pleomorphism. Not sure about mitotic figures, probably very few. Yeah, almost none mitotic activity, no necrosis, and they performed some basic immunohistochemical stainings and they weren't able to classify the tumor. So the basic panel includes ATRX protein. In this case, you can see it's completely lost in the tumor tissue. You should always check whether you have your internal control positive. So there are some non-tumor cells positive with loss of expression. This is compatible with astrocytoma diagnosis. And IDH-1 antibody was negative. So I performed genetic studies, and IDH mutation was there, but it was not the typical for which the antibody works. So some other very rare type of IDH. So together IDH mutation together with ATRX protein loss, this is IDH mutant astrocytoma grade 2, because no significant mitotic activity is present, nor necrosis. In addition, CDK and 2A gene was retained. There was no loss, so that's why it's graded as grade 2. My next case is again CNS, and it's not very nice, but you can tell it's meningioma, right? And when I see meningioma, especially when grossly brain tissue is present within the specimen, like it was probably here grossly, or microscopically, like here, you get brain tissue here and meningioma here. It suggests it's brain invasive meningioma, but otherwise, in this case, except for this brain invasion, which in former WHO classification indicated grade 2 automatically, nowadays we have this C impact. Now I think it's number 8 recommendation. If you see otherwise benign meningioma, so no mitotic figures, no worrisome features, no necrosis, low mitotic activity, no special type, only brain invasive, and I will show you GFAP staining. This is always good to confirm it's brain invasive. So we can see we have meningioma here and glial tissue entrapped within the mass of meningioma. So this indicates clearly it's brain invasive. So in this situation, otherwise benign meningioma, only brain invasive, you should do copy number evaluation. We do it with low pass whole genome sequencing, and in this case there are no copy number changes indicating it's aggressive. So compared to former WHO classification, with these recommendations, CIMPAC now 8, this should be graded as grade 1 brain invasive. So probably it will behave less aggressive compared to brain invasive with some copy number changes. So this is new. Next case is another consult case, quite interesting one. It's soft tissue mass in quite a young male patient. It's somewhere in soft tissue around knee, so knee region. You can see some soft tissues including skeletal muscle, fatty tissue, and this quite well circumscribed lesion, which shows this bluish myxoid or maybe chondroid looking matrix. And this is basically it. Nothing more to describe. Quite innocuous looking brownish, cytologically quite blunt cell, maybe a little bit plasmacytoid morphology. No big mitotic activity, no necrosis, no big atypia. And it was sent with 2 differential diagnoses, which seem quite reasonable to me, with mixed tumor or myoepithelioma of soft tissue, whatever it is, because it's probably non-existing entity composed of several tumor types. And the second differential diagnosis was extraskeletal myxoid chondrosarcoma. But this is cytokeratin staining. It was quite strongly and diffusely positive. So this is cytokeratin cocktail. In addition, EMA was quite diffusely positive. S100 protein was focally, I believe, positive. Yeah, some cells maybe. Yeah. So with S100 positivity epithelial markers, this is quite suggestive of myoepithelioma of soft tissue. But I have performed, of course, molecular studies, and it showed this very typical WSR1 and NR4A3 fusion, which is typical for extraskeletal myxoid chondrosarcoma. But recently it was described in case reports in something which authors called Cutaneous atypical myoepithelial neoplasm, whatever it is. So I believe it's extraskeletal myxoid chondrosarcoma in this case, with quite diffuse cytokeratin positivity, negativity for neuroendocrine markers, which are, I believe, only positive markers, repeatedly positive in extraskeletal myxoid chondrosarcoma, I and SM1 being the most frequently positive. So some extraskeletal myxoid chondrosarcomas may show cytokeratin positivity. It's written in the WHO Blue Book. I was not aware of that.
Yes,
and it's
very often.
And it's pitfall.
Actually, I hope for the close future, myopithelioma of soft tissues is bullshit, nonsense,
will disappear.
and will stop existing. Yeah.
Okay, so that's it.
Important thing, it's called extraskeletal myxoid chondrosarcoma, but it has nothing to do with chondrosarcoma.
Yeah.
The cells resemble chondrocytes, that's why the name was used in the past. But there is no relation to chondrosarcoma. There is never cartilaginous differentiation. There is never cartilage. Whenever you see cartilage in a tumor that looks a little bit like this, it's not this tumor.
Yeah, in WHO book is classified with tumors with uncertain line of differentiation. Yeah.
And it's the same group of tumors as so-called myoepitheliomas, but it's a complete mess.
Yeah.
Okay, good afternoon. It's Michael Jr. speaking. The first case, it's relatively easy. It's a adult patient with skin lesion. And there is this polypoid small tumor. Which on low power you can see it's very cellular. There is a lot of inflammatory infiltrate in the background, and the tumor is composed of these, it looks like little nodules of cells with eosinophilic cytoplasm, which are mostly spindle, but in some areas more epithelioid, especially when you go to the periphery, where presumably they are less compressed perhaps. You can appreciate this cytology better, epithelioid morphology better hopefully. And in this little area you can perhaps also notice that inside of the tumor cells, you have these little lymphocytes. There is a small halo, empty space around them, and these cells are lymphocytes which are located inside of the neoplastic cells. This is called what? I've shown this to the residents already. So do you know, guys? So what stain would you do with this morphology and this finding?
It's 100.
It's 100 staining, correct? And I would do OCT2 as well, but it doesn't work very well. So this is S100 protein. You can see the tumor cells are diffusely positive, and the lymphocytes are completely negative. So S100 staining will also highlight the emperipolysis, and this is obviously what diagnosis.
Rosai-Dorfman disease.
Exactly, yes. Rosai-Dorfman disease in the skin. It's pretty common. I see it a couple times a year in just routine biopsies. And other markers which are positive are histiocytic markers, so you can do whatever you prefer. I like PU1 because it's a histiocytic marker with nuclear expression, and you can beautifully see and locate the positivity. So most of the cells which are not lymphocytes are histiocytes, which are PU1 positive, but they are also CD163 positive. And you can do another marker which should be in this morphological context pretty specific for Rosai-Dorfman, and that's OCT2, but in our lab it's kind of
It is positive.
it's positive, but this is not
Definitely. It's always.
this is not impressive expression.
It is
So
positive.
it needs better titrating.
It's more specific also.
Specific, but the staining sucks.
Within the range of the tumors.
And next case, this was clinically called a lipoma of the shoulder. We are in soft tissues. So this ovoid tumor, which is quite myxoid, forms these reticular-like structures, or sieve-like structures if you wish, and it's composed of spindle cells which are pretty bland. There is no mitotic activity. Here in the middle you can see, for example here, this thin cytoplasmic process.
Is it DMA positive?
Yes, we should do. So this morphology kind of suggests neural differentiation, neural tumor, neurogenic tumor. So you can start with various markers of neurogenic tumors. One of them is EMA, which we see here, and EMA is a marker besides epithelial structures. It's a marker for perineurial cells, and in perineurial cells, it's notoriously quite weak. There is quite weak expression, as you can see here, but there is definitely an expression. This is not because the staining would be improperly set up. It's not because the concentration is not sufficient. It's because just perineurial cells express EMA so weakly. It's completely normal, and you should count with it. But this is nicely positive. So this has definitely perineurial differentiation. Here it's more striking, the positivity. So you can think of perineurioma. There are other perineurial markers. Which ones? The young ones? Do you remember which other markers we have for perineurial cells? You are the young one. Okay. Okay. Yes. It's GLUD1. This is GLUD1. GLUD1 is the most sensitive but least specific. But if this would be negative, I would be doubting it's perineurial. But this is super strong. CD34 you can do. I don't even know how it's stained here. There are some areas that show positivity. CD34 predominantly negative, and there is S100 protein as well. It's negative here. So I think this would qualify as retiform perineurioma.
Who discovered it and who described it first?
Yes, you.
Yeah. Very important.
Okay, so next case, this was a 60-year-old patient with a tumor on his back, I understand correctly, and it was sent with correct diagnosis just for molecular testing, but I thought this could be one pretty nice example of this tumor. So we have a skin lesion, which you can see the whole excision is full of something. There is something happening in the whole thickness. And first you check the epidermis, and there is something happening at the dermoepidermal junction. Probably there are some nests of weird atypical looking cells, so probably some melanocytic lesion. And then, so let's stay at the junction. And these cells are kind of epithelioid, ugly, atypical, but epithelioid. But as you go to the bottom, they kind of change in phenotype to still very atypical, but spindled cells. So it's not epithelioid anymore, but they are spindled. And you can tell that they are highly infiltrative. They infiltrate deep down to the subcutis. One more very important feature is this. What is this? You see it in all sorts of lesions. That's quite good clue for this tumor. This is lymphoid aggregate. So this tumor very often has these lymphoid aggregates at the periphery. And that's a good, important diagnostic clue because not all tumors, this is basically, anybody has a suggestion?
Desmoplastic melanoma.
Desmoplastic melanoma, perfect, yeah. So this is desmoplastic melanoma. Some of these tumors, they are like a mixed type with conventional superficial spreading melanoma, as you can see here. Some desmoplastic melanomas are purely spindled, you don't see any junctional component, and those cases are obviously much more difficult to diagnose. Also, many desmoplastic melanomas are not so striking as this one. Here you don't overlook it, but those that are smaller and not so prominent, then you very much appreciate if you notice these lymphoid aggregates, which are usually there and can help you to realize that there is the tumor. Anybody who knows what stains would be positive in this tumor? Suggestions do you have? So it's a melanoma, so it should be positive. S100 SOX10 almost always positive in desmoplastic melanoma, but HNB45 and these other markers in desmoplastic melanoma are almost always negative. So don't get discouraged by that. So we did molecular. There was NF2 mutation, which is kind of surprising. Typically you see NF1 mutations, but there's also third mutation, some other TP53 mutation, everything you find commonly in melanoma, and also very, very high tumor mutational burden. Desmoplastic melanoma has the highest tumor mutational burden of all known neoplasms. In other case, otherwise this tumor occurs in the sun-damaged skin, typically, so head and neck location. So next case, this is old male. It was also somewhere on the back of the neck or something like that. And again, we see something happening at the junction here. Some nests of pretty atypical melanocytes. And again, if you go deeper, you see much less striking, but still pretty well obvious proliferation of these atypical spindle cells. And here, small lymphoid aggregate. So here I have IHC stain. It's an old case, so might be a little faded, but yeah, you can still see pretty well how deeply the tumor cells infiltrate. You can see the atypical cell here at the bottom. So this is typical staining for desmoplastic melanoma.
The cells are typically very thin, tapering, polar. It's very typical desmoplastic melanoma. It's not seen in many other tumors. Yeah, you must get it into the eye.
So when you get a biopsy like this from the skin, this is textbook example, I would say, on low power. See this another case. Yes. Again, head and neck, old patient, huge lymphoid aggregates, and some very cellular, ugly-looking lesion growing through the dermis into the subcutis. Another desmoplastic melanoma, of course. And I think this case didn't have much in the. Maybe here's remnant of some melanocytic lesion, but doesn't look really atypical to me. Not sure, but S100 protein.
If you find inside the component, it's usually lentigo-maligna component.
Yeah. And the inside component, obviously, you find much better with S100 or SOX10. So this is probably the rest, or this is the remnants of the inside region. Perhaps in other sections we would find something more striking. But then again, look how deeply it grows. And whenever you have a perineurial infiltration, which is pretty common, the prognosis is much worse if there is perineurial infiltration.
And usually it goes around nerves deeply along the nerves, so that the amputation must be much bigger than you would guess from the H&E slide. It can be centimeters away from the main lesion, the perineurial differentiation of this tumor. Yeah.
But as far as I know, if there is no perineurial infiltration, perineurial invasion, the prognosis is actually much better than for conventional melanoma. And actually these tumors, perhaps because they have such a high tumor mutational burden, they react very well to immunotherapy.
There's another pitfall regarding melanocytic lesions with desmoplastic features. There's something called desmoplastic melanoma-like metastasis of conventional melanoma. So, but in these cases, your best friend is the clinical information that the patient has got melanoma excised previously.
Okay, this is another case, another topic. This was a lady with a low-grade mucinous I think mucinous carcinoma of the ovary. And she already had hysterectomy and stuff, but now she already also had a resection of omentum and some lymph nodes. So I got this. This is just a routine case, and I got these sections from the omentum, and it's a patient with known diagnosis of carcinoma. And then in the omental fat, you have these little islands of epithelioid cells, which might make you wonder if it's not a disseminated carcinoma. Of course, it's the patient has a mucinous carcinoma, so this is not mucinous, but you can find this also in other types of carcinoma.
That's nice. Yeah.
Epithelioid cells.
Good boy, good people.
Forming these little nodules or clusters. Any suggestions apart from the two senior people here? What you should think about? Of course, it's epithelioid.
I won't tell.
Mesothelioma or mesothelial cells. Perhaps some mesothelial hyperplasia, right? Could be.
It's benign.
It's good suggestion, but wrong one. Yeah.
But it's a very reasonable suggestion.
Definitely.
What other things could this be? The cytology is very important here. There are no mitoses, and if you look at the nuclei, some have again these nuclear grooves. They are kind of raisinoid shape.
Coffee bean or raisin, yeah.
Coffee bean-like shape, and eosinophilic cytoplasm. What this could be for what type of cell?
Histiocyte?
Histiocytes, perfect. So if you would do histiocytic markers, this would be completely positive, everything. And these are basically reactive lesions.
It's very specific histiocyte, yeah.
Basically reactive lesions which can occur in any kinds of conditions. They can be associated with carcinoma, but also with operation, inflammatory changes. They can occur everywhere in the body, and sometimes in locations like this can be mistaken for carcinoma or some epithelioid neoplasm.
Actually, it's quite a common thing.
Without knowledge of this entity, you do not know a lot of organ pathologies. This paper should be known by heart. This one, yeah.
And we had a paper back in 2016 where we basically because these lesions they have been described in many different organs, in the heart, in the thymus, in the GYN tract, and others, and in every organ they have been called something else. Most commonly they were called nodular mesothelial histiocytic hyperplasia. This is the name that was used and still is often used for these lesions on the peritoneum or just mesothelium-lined cavities, so also in the thorax. And they are called mesothelial/histiocytic hyperplasia because on the mesothelial line spaces you often have some mesothelial cells as well associated with this histiocytic nodule. But you can have them, as I mentioned, everywhere, almost everywhere, and they are everywhere the same thing. They are just reactive histiocytes, completely benign, and their only significance is that they are often thought of as possibly neoplastic epithelial cells. You can see here this beautiful high-power picture where you can see the raisinoid shape. It looks like a raisin, kind of like a uneven nuclei. Some of the nuclei also have this nuclear groove. It can be pretty impressive in some cases, such as here. Here you can see it in the thymus. And everywhere, in all locations, they are positive with various histiocytic markers. Back then we didn't have PU1, but it would be PU1 positive as well. So this is example in the skin. There it is called intralymphatic histiocytosis in the skin, but it's still the same thing as, for example, here, this is high-grade serous carcinoma in the ovary, and around it, all these cells, they are not carcinoma cells, those are histiocytes. So this is a good thing to know.
It's in the skin as well very often, yeah?
That's what I showed.
Mediastinum, it's in everywhere you have pneumothorax.
This is a skin lymphatics.
It's in umbilicus when you have some injury to umbilicus.
This is a pretty good paper to have at site. You don't have to read through it, but look at the pictures and memorize the morphology.
All young pathologists here in the room should know it by heart, yeah? Every article of that, every part of the paper is full of information, and you will see it many times in your life.
Okay, so another case, 72-year-old male, and these are soft tissues in the gluteal area. There are areas of fibrous tissue with not much, but then areas where you can see cellular neoplasm, a little bit myxoid, on higher power. You see this quite ugly looking round epithelioid cells. It's hard to say sometimes. There's quite some cytoplasm, but they are very uniform. They look pretty much similar to each other, but not super uniform like you see in Ewing sarcoma. When you see Ewing sarcoma, small round, it's like a prototypical small round cell sarcoma. The cells look like exact copy of the other, but here there is some variability. They are uniform, but not 100%, not perfectly uniform. The cells have quite a lot of eosinophilic cytoplasm, which usually is not the case in Ewing sarcoma. But still, you can have unusual variants of Ewing, which can look like this, pretty much. So it's not excluded. The diagnosis of Ewing sarcoma is not excluded, so it's definitely reasonable to do the basic markers. CD99 is a useful marker for Ewing. It's completely useless for anything else in soft tissue pathology. Don't use it unless you think of Ewing. Many people just stain it for all sorts of tumors, but it's pretty useless stain. It's quite unspecific. But if you see diffuse membranous expression in a tumor that that is basically composed of small round cells, it kind of points you towards that thing being really Ewing sarcoma. So here we see expression, we even see some membranous expression, but this is definitely not diffuse and strong. It's kind of multifocal, patchy, and not really that strong. So this would be not optimal for Ewing. You can also do NKX22, that's another marker of Ewing sarcoma, which is positive in almost all cases. It's not very specific, but it's very sensitive. So it's very sensitive, but it's negative here. So it's, again, pulls you away from Ewing sarcoma. Also, the patient is 72 years old, which would be, it's possible for Ewing, but it's would be unusual. Another marker for Ewing sarcoma is PAX7, which is also a marker for skeletal muscle differentiation, but at the same time, it is positive in almost all Ewing sarcomas. You can see it's negative here as well. So any other suggestions what this could be? What would be your other thought? Zahra, do you have a suggestion? What other round cell sarcomas we have?
DUX4 staining.
Yeah, you can do DUX4 staining. DUX4 immunohistochemistry should detect all CIC-DUX4 sarcomas. CIC sarcomas is another group of round cell sarcomas, and DUX4 is the most common fusion partner in more than 98-99% of cases. And this is DUX4 immunostaining, and if it shows nuclear positivity, it's very, very specific for CIC-DUX4 sarcoma. So we see nuclear positivity. We also did RNA sequencing, and there is CIC-DUX4 fusion, which confirms the diagnosis of CIC-DUX4 round cell sarcoma, which is a very aggressive neoplasm. It's more aggressive than Ewing because it doesn't react to the Ewing chemotherapy. The next case was a 22-year-old male with a tumor on his thigh. And we have this pretty large, very, very cellular neoplasm with entrapped adipose tissue. Some storiform arrangement, some fascicular arrangement. In most areas, the tumor cells are spindled. So do you have any? Does this ring any bells in your head? Any suggestions what this could be? What would you stain? So this would be, I think first differential could be Dermatofibrosarcoma protuberans, right?
Yeah, correct.
So we did CD34, and indeed it's diffusely strongly positive. The problem is it's not Dermatofibrosarcoma protuberans. One hint which should pull you away from that diagnosis are cells like this one here in the middle, the hyperchromatic spindle cell. So there's atypia.
Yeah.
The FSP, Dermatofibrosarcoma protuberans, those are very uniform, monotonous spindled cells. And here you see quite a lot of pleomorphism. Although most cells are spindled, you'll find some epithelioid cells or more plump spindled cells. You will find hyperchromatic cells, as I've just shown you. There's also dispersed inflammatory infiltrate, mostly composed of these lymphocytes in the background. And there's also a lot of eosinophilic cytoplasm in the tumor cells with this kind of, it's called glassy cytoplasm. It reminds you of this type of glass, jak se tomu říká česky? Mléčné sklo.
Ground glass.
Ground glass cytoplasm. So any other suggestion what this could be?
Let's be honest.
These are cytokeratins, AD1, AD3, broad spectrum cytokeratins, which show multifocal positivity, which is typical for this tumor.
P53?
P53 I didn't do. This is WT1, which shows nuclear positivity in many tumor cells. Again, 80% of these tumors stain with this. And this is SYNCAM3, which is a marker designed specifically for these tumors, and this is so-called superficial CD34 positive fibroblastic neoplasm, fibroblastic tumor, described by Andrew Fulp 10 years ago, and it's a mimicker of various high-grade sarcomas. This case I show you here doesn't, it's not likely to be called high-grade sarcoma, but other examples can look really pleomorphic, really ugly. They can have many of these hyperchromatic cells you see in the center. The clue to this diagnosis, or the clue that this is not high-grade sarcoma, is that you basically don't find mitotic figures, not even speaking of atypical mitosis. You don't see necrosis, you just see pleomorphism. By definition, diffuse CD34, 80% cases have cytokeratins and WT1, and SYNCAM, and there is antibody called SYNCAM, which should be positive in all cases and should be pretty specific. About half of cases have PRD-M10 fusions. And it's important to recognize because although it looks like sarcoma, it's pretty much benign. Out of 30-40 cases, just one metastasized to lymph nodes. Otherwise, all cases were basically benign. Next case was a 44-year-old male with a tumor in his retroperitoneum and also in his pancreas. So this is a sample from the pancreas. So high-grade neoplasm, definitely, but in these areas it looks like quite uniform round cell tumor. Myxoid in some areas. This looks more like some mix of fibrosarcoma, perhaps a little bit. So this is from the pancreas. Cytokeratins were negative, and it doesn't really look like carcinoma anyway. Here again, a little bit different morphology, more spindled. And actually, the clue to the diagnosis, morphological clue, is in the other sample, which was somewhere from the omentum. It looks very different here. It's much more pleomorphic. You can see these bizarre hyperchromatic cells, a lot of inflammation in the background. So the tumor has the heterogeneous morphology, unless we can think that these are two different tumors in one patient, but it's very unlikely in the same location. So this looks like the tumor has a heterogeneous morphology probably, and because we are in the retroperitoneum, we should do definitely MDM2, and we are looking at something that looks like a sarcoma, right? So MDM2 immunohistochemistry is here, and indeed multiple or large part of the neoplastic cells are strongly positive in their nuclei. MDM2 fish was positive, so this is this could be a dedifferentiated liposarcoma given the monotonous morphology in the first sample. I also considered GLI1 sarcoma, which also can have MDM2 overexpression, but this is GLI1 immunohistochemistry, which was negative. And this other morphology in the second sample, this pleomorphic morphology, would not be characteristic of GLI1 sarcoma. So this was called dedifferentiated liposarcoma of the retroperitoneum. Anytime you see non-epithelioid and non-hematolymphoid malignancy in the retroperitoneum in an adult patient, or especially in older patients, think of dedifferentiated liposarcoma. Okay, one more case. This was adult, male, 30-40 years of age, and these are samples from various skin locations. So this was described clinically as a multifocal, probably vascular lesion. It was. I can maybe first show the pictures. Clinical pictures. So that's one location. You can see dark red lesion, and the other picture I have is this one, somewhere on the trunk, multiple dark red foci. And if we go back to histology on low power, you see indeed some large dilated vessels, but not only vessels. There's also this round cell component to it, very bland, but cellular roundish cells with quite characteristic morphology. Residents have any suggestions? Glomangioma, perfect. Yeah. So these are so-called glomoid cells, so roundish or almost epithelioid cells, like they have a lot of eosinophilic cytoplasm. They have this quite even spacing from each other. And you can see them in the glomus tumors, which basically look like this tumor here, but without the vessels. And if you have glomus tumor with a lot of dilated vessels, you have glomangioma. It's kind of spectrum of these tumors. They are typically solitary, typically on the fingers, but can occur pretty much anywhere, including internal organs. Cases of glomus tumor in internal organs are probably somewhat different tumors with different genetics, and they are much more aggressive. Those on the skin are usually benign lesions. There's one very useful clinical clue for glomus tumors. Anybody knows? They're typically very, very painful. Perfect. And there is a rare thing called multifocal glomus tumors. They are typically caused by germline mutation in a gene which is easy to remember. It's called glomulin, GLMN gene. And people with these germline mutations will have multifocal. This is another section from different lesion. Glomangiomas typically. Smooth muscle, if you would do immunohistochemical staining for smooth muscle actin, there will be diffuse positivity. Last case, probably the most difficult one, but the most interesting one, perhaps for some of you at least. This is a consult from Brazil, 52-year-old male with an intramuscular nodule on his left arm. You can see it's indeed intramuscular. We have these fragments, some again lymphoid aggregates at the periphery. The tumor is again cellular, mostly spindled, but again, the cytology is quite variable. Spindled ovoid. You can find occasional more epithelioid cells. Again, a lot of inflammatory background. These tumors have many histological features overlapping with the superficial CD34 fibroblastic tumor, including the inflammatory background. You can see here as well, inflammatory infiltrating the background. Very often both tumors have also this thing here, histiocytic aggregates. And you can also find calcifications in both tumors. Pretty often, those are all features of a long-standing lesion, tumor that has been there for many years. Chronic inflammation, histiocytes, calcifications, hemorrhage also. So if you would be helpless, and you can easily tell this is mesenchymal lesion, and you don't know what it is, besides being mesenchymal. So what would you do? What stains would you do? Some basic staining for mesenchymal tumors. Any suggestions?
EMA, Desmin.
EMA, Desmin, S100 protein, cytokeratins A1, AE3. S100 protein, maybe I've said that already.
Yeah. This is Desmin, probably.
This is Desmin. This is diffuse Desmin positivity. All the cells are strongly positive for Desmin. So that, of course, narrows down your differential. Most likely, this kind of diffuse Desmin staining would be in some myogenic tumors. So you can think leiomyosarcoma, you can do caldesmon, actin. Actin might be focally positive. H-caldesmon, the right clone. It's important to have the right clone, HCD clone, which is very specific for smooth muscle. The other clone is useless. It's stained everywhere. So those would be negative. Caldesmon would be negative. So we can also think of the other myogenic tumors, that means skeletal muscle tumors. And for those, we have other markers. What could this be? There's one here. What marker do we have for skeletal muscle differentiation? Zahra, do you know? MyoD1 or myogenin, yes. Actually, if we would do myogenin in this tumor, it would be most likely completely negative. But MyoD1, you can see some expression here. It's a nuclear marker. Myogenin, both myogenin and MyoD1 are nuclear markers. They are nuclear transcription factors. And we can see pretty strong and multifocal MyoD1 expression. So this is tumor with skeletal muscle differentiation. So we can think of some rhabdomyosarcomas. If we go back to this tumor, there's one thing that doesn't really fit with rhabdomyosarcoma, and that is basically complete lack of mitotic activity. There are no mitotic figures pretty much throughout the tumor. And
inflammatory background.
Inflammatory background, also not typical of rhabdomyosarcomas. So we could think of this new entity, which used to be called inflammatory leiomyosarcoma. It was described in 1995 as inflammatory rhabdomyosarcoma. Inflammatory leiomyosarcoma. but we have shown actually 2017 or 18 that these tumors express skeletal muscle markers, and since then it is thought of as skeletal muscle tumor. Other studies have confirmed overexpression of genes involved in skeletal muscle differentiation, and some cases have been described with skeletal muscle differentiation with rhabdomyoblasts, basically. So this will be a new entity in the upcoming WHO in soft tissues, and this is the morphology. We've seen these histiocytic aggregates, very common. Calcifications are usually present. Quite, again, pleomorphic, variable cytology, spindled cells most commonly, but you can often find rhabdomyoblastic differentiation. And clue to the diagnosis, again, is lack of mitotic activity. So again, many overlapping features with superficial CD34 fibroblastic tumor, but inflammatory rhabdomyoblastic tumor is always CD34 negative.
It's very important because it behaves benign way. You know?
Yes, it's
so you could let amputate the patient the leg, and most of the tumor never metastasize. Yeah? Look how mild it is. Yeah.
It's important. Again, there's another tumor that looks like a high-grade sarcoma, but it's pretty much benign in most cases. However, other studies have shown that some unknown fraction, small percentage of the cases can actually progress to rhabdomyosarcoma. Rhabdomyosarcoma arising in inflammatory rhabdomyoblastic tumor, which is kind of interesting because now we have this tumor which is basically a precursor to rhabdomyosarcoma that has never been thought of. It can happen. We have benign rhabdomyomas and they never transform to rhabdomyosarcomas. And all rhabdomyosarcomas we've had until recently were always sarcomas from the start. And now we have this tumor, which can transform to rhabdomyosarcoma, and also we have now biphenotypic sinonasal sarcoma, which is a sarcoma in head and neck, which also is a pretty much benign tumor, but can occasionally transform to rhabdomyosarcoma.
Very typically, it's big tumor. It's 10, 20, 30 centimeters big tumor, yeah. And if you don't know it, you confidently make diagnosis sarcoma, yeah? And it's benign, yeah. The old name of it is inflammatory leiomyosarcoma. It's the old name of it, yeah. No,
so if you want to know more, this is a review of.
This is best paper, I guess.
I wrote recently.
It's a Meningeal paper, yeah.
And it's a review article in a journal which is supposed to be like a easy source for information. So they forced me to do a lot of tables and stuff, so you can easily find information there.
Without this tumor, you don't know soft tissues. You know?
Okay, thank you very much for listening, and we will see you next week again. Bye-bye.